For the invitation to share the evolving science and data on epidemics at this 15th ELAD conference on new anti-epileptic drugs and devices. This is truly a unique and unprecedented conference. My name is Volker Knappertz. I'm the Chief Medical Officer of GW Pharmaceuticals, and I'm an employee of Greenwich Biosciences, a wholly owned subsidiary. These are my disclosures. Cannabidiol, CBD, is derived from the cannabis sativa L plant. It has shown protective effects against seizures in vitro and in vivo preclinical models. And due to its apparent lack of euphoric effects, it is clear pharmacologically that it does not interact at the concentrations reached with cannabinoid receptors, namely the CB1 receptor, and therefore doesn't exhibit those typical effects that many recreational users are seeking. It has a unique multimodal mechanism of action, and we were able to demonstrate efficacy on the primary seizure reduction endpoints in 5 consecutive randomized placebo-controlled trials at all doses tested. This is the first and only FDA and EMA approved cannabinoid medicine as Epidiolex, both in Europe and in the US. The mechanism of action of cannabidiol remains unknown. However, we have established some evidence surrounding 3 distinctly different mechanisms that are involved in CBD's ability to reduce seizures. The first is a G protein coupled orphan receptor called GPR55. We know from knockout animal data that a substantial amount of the efficacy in the MEST model is abrogated when the GPR55 receptor is knocked out. The same is true for the TRPV1 channel. And additionally, there is evolving evidence that CBD inhibits adenosine reuptake via the ENT1 transporters in the synaptic cleft, therefore increasing adenosine there. Let's take a look again at the PK metabolic and drug-drug interaction profile. CBD is readily absorbed and appears rapidly in plasma after oral dosing. The peak through trough fluctuation remains low, and the exposures across the therapeutic range are slightly less than dose proportional, but by and large they're dose proportional. The half-life is very long, with around 60 hours, and there's extensive metabolism, mainly through oxidation via multiple CYP450 systems. There's also conjugation and glucuronidation. There's 2 significant metabolites to consider. One is the abundant inactive metabolite 7-carboxy-CBD, and of interest also the 7-hydroxy-CBD, which is an active metabolite that has anti-seizure properties in its own right. The oral bioavailability of CBD is poor in the fasted state with only 6%, but that is increased significantly to 3 to 5-fold this with a high-fat meal, but even with a glass of whole milk, this can be increased by about 3-fold, yielding about a 20 to 30% oral bioavailability in the high-fat meal stages. Let's look at the PK interactions that are prominent with clobazam and CBD. Here I will show you the increase in the active N-desmethyl clobazam metabolite, which is about 3-fold in the co-administration with CBD. And you can see that this is a bidirectional interaction where both the active metabolite of clobazam and the active metabolite of CBD, here the 7-hydroxy-CBD in the lower bottom of the panel, are increased, increasing active moiety, therefore, of both parent drugs. Let me take you to the clinical development program and remind you of the studies and how they were designed. There are 5 trials, 2 in LGS, 2 in Dravet, and 1 study in tuberous sclerosis complex. These studies had very similar designs in that they were assessing baseline seizure frequencies and compared a treatment period of 14 to 16 weeks, comparing to the baseline. What was different was the definition of the primary seizure types. It was drop seizures for LGS, convulsive seizures for Dravet syndrome, and TSC-associated seizures for tuberous sclerosis complex. These are the trial designs. As I said, a 4-week baseline period builds the denominator, and then the 14-week treatment period is the observations of the seizure frequency during the treatment period. Note that there's a 2-week titration period where people are titrated up then to the highest dose. Here you can see the different dose titration schemes between the clinical trials and also the different dose titration as it is now in the US and in the EU label. What's important is in the clinical trials, we performed a forced titration to the 20 and 25 milligrams within 11 days. In the labeled titration scheme, that forced titration to the higher doses is omitted. And for LGS and DS, the label is asking you to titrate to 10 milligrams and then assess efficacy and safety, and then consider higher titrations for those patients who need more efficacy once they tolerate it at the 10 milligram dose. For the trials, these were largely young patients. Age range of the means was between 16 and 9 years of age, depending on the indication. But there were adult patients both in the TSC and in the LGS studies. The DS was capped at the age of 18. There was no gender difference. These patients were refractory to the existing medications, with the median number of concomitant AEDs in the trials was 3 AEDs throughout, with prior AEDs higher. The baseline seizure frequency numbers were high for the syndromes. The co-medication is listed here across the studies. Importantly, the indications have a high frequency of both valproate and clobazam. Both of these form the basis of significant drug-drug interactions with CBD, and I want to remind you of what that interaction looks like. Here again, in a later slide, here again, you see the efficacy data on the treatment arms from the 5 trials, and as you can see, the efficacy is consistent across these syndromes and is observed in all those arms. Regarding the effect modification or potential effect modification of concomitant clobazam, I'm showing you here the results from a recently published meta-analysis where we were looking at the with clobazam group and the without clobazam group. As a reminder, clobazam was not randomly assigned. It was the co-medication and is therefore subject to significant confounding by the indication for the use of clobazam or not. As you can see here in the top panel, when you compare the reduction in seizure frequency with clobazam, you see the treatment ratio is 0.59, signifying a 41% advantage in the seizure frequency overall versus placebo, taking all seizures into account. That is 0.85 for the without clobazam group. And then looking at the 50% or higher responder rate, we express that as an odds ratio of reaching that proportional response, and the odds ratios between with and without clobazam of reaching a 50% responder definition are very similar, with 2.5 and 2.4. Both of these also reach nominal statistical significance. Of interest, both from a timing perspective of the onset of action, but also from an understanding of at what doses the efficacy starts to surface. We performed analyses by days, and as you can see, the efficacy onset and clear separation from placebo occurs within the first week of titration, when all patients are still moving towards the 10 milligram per kilogram per day dose. The same is true for the tuberous sclerosis clinical trial data, that the onset of efficacy occurs in that first week when the titration is moving towards the 10 milligram per kilogram per day dose, and substantially underlines the early onset of efficacy and efficacy at those lower doses. Let's take a look at the safety profile of cannabidiol as it is evolving. There are more AEs with regards to frequency in CBD than in placebo across our clinical trial program and across doses. Most AEs are mild or moderate in severity. There's a dose-response relationship with more AEs, especially of somnolence and sedation, GI effects, decreased appetite, diarrhea, and nausea, but also a dose response on the transaminase elevation and the potential for drug-induced liver injury, as well as rash. The dose-related elevations of the liver transaminases are observed with CBD treatment, most commonly in those taking concomitant valproic acid. They are typically occurring within the first 60 days of treatment, and therefore make the monitoring for those abnormalities effective. They are reversible either with discontinuation, dose reduction, or in some cases without any changes to the concomitant medication. The liver testing needs to be performed according to the US and EU labels and will allow for the safe titration and maintenance when followed. Importantly, I wanted to draw your attention also that the interaction with clobazam increases somnolence and sedation, rash, and also pneumonia significantly. Let me show you some of the data with the clobazam interaction with clobazam to the left and without clobazam to the right that illustrates the contribution of that interaction to these adverse events of special interest. For somnolence, you can see that the placebo rate is 21% with clobazam and goes up to 50% in placebo with clobazam and goes up to 50% with 10 milligrams CBD and almost 60% with 20 milligrams of CBD. As we look in the without clobazam arm, you see no difference to the placebo frequency of 12% in the 10 and a doubling of that rate to 24% in the 20 milligram arm. This is also reflected in the occurrence of pneumonia, which occurs in 14% of the 10 milligram arm with clobazam, and no patients had pneumonia in the 10 milligram arm here as an example without clobazam. So by and large, it is reasonable to assume that there's an interaction between the somnolence symptom complex and the pneumonia occurring, and we wanted to draw the prescriber's attention to this precaution. With regards to the interaction on the drug-induced liver injury, which is defined here in this slide as an ALT over 5 times the upper limit of normal, you can clearly see the synergistic effect that the valproic acid co-medication has. As you can see, those patients that are on valproic acid make up the preponderance of the cases with greater than 5-fold increases in ALT, up to 3% here in the 10 milligram arm, and then going to 11% in the 20 milligram arm. There are no meaningful elevations at the 10 milligram arm of VPA, but there's a slight increase in the frequency of drug-induced liver injury levels of ALT with the 20 milligram and higher doses. So in closing, CBD It's now been marketed in the United States for approximately 18 months and recently had a market introduction in some of the core European countries. It has a unique multimodal mechanism of action. A lot of work still remains to be done there. The efficacy has been demonstrated in 5 consecutive trials, and the safety profile is now fairly well established and has been consistent both in the across the syndromes in our clinical trials, but also in the marketed setting and the post-marketing surveillance. Both the low and high doses had similar seizure reductions, so the safety profile should be assessed at the lower doses with dose titration to higher doses reserved for those patients that do not have satisfactory control of their seizures following the observation at the 10 milligram per kilogram per day dose. As we mentioned, these Epidiolex is now approved in both Europe and the United States, and they are currently the filing for the expansion of the indication section of the label in both jurisdictions, Europe and in the US, is under review for the treatment of seizures associated with tuberous sclerosis complex. I wanted to thank again the organizers for inviting us to give this overview, and I'll be available for answering questions.
Thank you very much, Dr. Knappertz. We appreciate your overview of CBD. We have a few questions coming in, and I invite the participants to please submit them through the Q&A. Let me start with a question from Professor Bieler. In light of CBD's low bioavailability under fasted conditions of 6% and under fed conditions of 25%, he asked whether you think that a lymphatic targeted formulation might be able to increase CBD oral bioavailability and decrease its food effect, or maybe you could comment on other formulations that might be in development.
Thank you, Professor Bieler, for this excellent question. we are looking into multiple ways and have been looking into multiple ways of increasing the bioavailability and beyond that of really targeting the lymphatic absorption, which would then shuffle some of the CBD at least around the liver and into the systemic circulation prior to transformation in the liver. We call that actually the holy grail of development of new formulations of CBD. So it's a very important topic and can help with the overall volume of CBD that would need to be administered. So we're pursuing these type of formulations. Let me just say this, it is much more challenging than we believe. These cannabinoids are fairly unique class of molecules, highly lipophilic, and have other characteristics that make it challenging. But yes, it needs to be pursued, and lymphatic absorption would be particularly useful. So we would reduce the load on the first pass in the liver.
Thank you very much. We have a question regarding dosing of CBD in patients with TSC, and specifically, can you comment on why you might think TSC patients require a higher dose than either Lennox-Gastaut or Dravet's syndrome?
Yeah, so I think there's a historic component to the development program that's important to understand. This is an orphan development program where we conducted, as I said, 2 studies in DS, one with 20 and placebo, the other one with 10 and 20. We did the same for LGS. And as the program was designed and these data were not available from the phase 3 trials, the decision was made to use 25 and 50 milligrams for the TSC trial, mainly because the open label data from the expanded access program was suggesting that those doses were tolerated and were considered that the exploration of the higher end of the dose range was warranted because they were tolerated and showed some signs of efficacy in the open label trials. There's no particular reason to believe that TSC will require a different dosing range. And our proposal to the regulators is to include the 25 milligrams to anchor it to the clinical trial data and to the evidence into the titration range for TSC. I think there's more work eventually needed. I showed you the time to onset of efficacy data for LGS and DS. The TSC curves look very similar. So per se, from the limited data we have, because we didn't test doses below 25, I have no reason to believe that there's a substantially different dose response relationship to the TSC-associated seizures, which by and large were focal in onset.
Thank you. So maybe one more question before we go to the next presentation, but we will have some time in the general discussion for some of the others. Cecilia Johansson Landmark has a comment and really a question embedded in there regarding the safety and increased adverse effects in combination with clobazam. She asked, are these cases perhaps PK related and perhaps not accounted for? And basically, could you, by reducing the dose of clobazam and following the concentrations of clobazam and the active metabolites, could you perhaps reduce the side effects and what effect that might have on efficacy as well?
Yeah, so from our clinical trial program, we don't have a lot of data on this, but I think all of your suggestions there sound reasonable to me. I would defer to the clinical practitioners and maybe share their experiences of those who are doing this a lot. Obviously, there is a strong suggestion that the N-desmethyl formation plays a significant role in these adverse events that I was listing, and therefore reduction in the doses where feasible is a very prudent strategy, I would think. The issue is that in the clinical trial paradigms, we discourage dose reductions, and in fact, few dose reductions occurred, so we can't speak to this with data at this point. But what we're hearing from the high volume prescribers in the United States is that they are reducing doses when they see signs of somnolence and sedation occurring.
Thank you, Volker. I think we will save the other questions for the general discussion, and we'll invite you back for that in a few minutes.